Hello, everyone. I'm Daniela Filipescu, WFSA President, wishing you all a happy World Anesthesia Day 2025. This day brings our global community together to celebrate progress and recognize the vital role of anesthesiologists in safe, affordable emergency care. Our 2025 theme, Anesthesiology in Health Emergencies, highlights how essential we are in crisis, often on the front line, providing life-saving treatment. WFSA work on this year's annual theme includes focus statements at WHO meetings, new educational resources such as a new tutorial of the week package for health emergencies, a special update in anesthesia issue, and a series of webinars held over the year and also happening today, a chance to learn, connect, and share. Join the webinars. Share your stories through the dedicated photo booth and In Your Shoes campaign, and help us make the World Anesthesia Day 2025 unforgettable.
Hello friends, I'm Sheila Maitra, Chair of the Intensive and Critical Care Medicine Committee of the WFSA. Welcome to the WFSA Marathon session. We have 4 focus webinars with lectures and interactive panel discussions, highlighting the pivotal role of anesthesiologists in managing health emergencies from disaster response to critical care crisis. The sessions will explore preparedness, rapid decision-making, resuscitation expertise, and leadership of anesthesiologists as part of multidisciplinary teams in various health emergencies, underscoring their indispensable role in saving lives when seconds count. Thank you for joining.
Thank you for being with us. On behalf of the WFSA, we're really glad to have you in our World Anesthesia Day with this tremendous academic marathon. Today, I'm going to share with you my slide. I'm Hans Garcia from Bogota, Colombia. I'm a cardiac anesthesiologist and intensive care physician. I was working in the military for 26 years. I get retired this year. And right now, I'm going to present you my co-chairs for today. Dr. Sharon Einav from Israel. She's a double-board anesthesiologist and intensivist with master in clinical epidemiology with over 25 years of ICU experience and 12 years in the national EMS. She currently serves as a regional director of the chair at the IRB and Maccabi Healthcare Services. She is the deputy director of critical care and Cochrane sign-off editor with more than 350 peer-reviewed publications. Dr. Kajal Jain from India. She's a professor and head of the Department of Anesthesia and Intensive Care at PGIMER, sorry. She also serves as the course coordination of the DM in trauma anesthesia and acute care. Today, our agenda for our webinar, we are going to talk about the patient blood management as evidence-based patient-centered approach. The second lecture is management of coagulopathy following trauma. And our last lecture will be minimizing cerebral hypoxia in severe traumatic brain injury. After that, we're going to have a panel discussion, so interesting for you. I just want to remind you that we will have our Q&A sessions at the end. You can use the box on the below the screen. And also we have the translation. You can use the AI translation for live subtitles. Please just select your language. And I just want to remind you that these lectures will be recorded and will be open for us on the YouTube maybe really soon. Dr. Kajal, please.
So, good afternoon and welcome to this World Anesthesia Day celebrations. And it's my honor to introduce our first speaker for the session, Professor Sibylle Langenecker, who is a highly respected leader in the field of anesthesiology and intensive care. Dr. Langenecker began exploring perioperative bleeding management during her medical training and quickly developed a strong interest in the field. Through her research, contributions to the national and international guidelines, her educational initiatives, and innovative approaches to knowledge transfer, she has played a key role in bringing patient blood management to the bedside. So please join me in welcoming Professor Sibylle Langenecker, who will speak on patient blood management and evidence-based patient-centered approach. To you, Dr. Langenecker.
Dear colleagues, it's a great pleasure and honor for me to be part of this connecting project. My topic has been told to you already. I'm an anesthesiologist and intensive care physician from the small country of Austria, and it's really a privilege to be part of this webinar today. Here's my declaration of potential conflicts of interest and my declaration of interests. So I will present management of severe bleeding emergency from the perspective in elective surgery and do extrapolations in trauma bleeding emergency as well. The title already gives the answer what PBM is, because the definition of PBM is it is an evidence-based interdisciplinary concept to manage anemia, optimize hemostasis, minimize blood loss, and allogeneic blood transfusions. Why? In order to improve our patients' outcomes. So already in 2011, the World Health Organization, WHO, stated that the potential short and long-term hazards of allogeneic transfusions have been underestimated so far, and they failed to show a benefit after transfusion. The global answer, our global answer to this revelation is restricting allogeneic blood transfusions, avoiding indiscriminate plasma and platelet transfusion as well. And this requires preventing anemia and bleedings. Together, transfusions, anemia, and bleedings have been referred to as the lethal triad. Later, last year, actually in 2024, the WHO gave us a guidance on how to implement this helpful project and concept of patient blood management. Why? Because they recognize that it does improve global blood health status. You can download all these materials free of charge from the WHO. I just want to highlight that this publication gives ideas how to reduce not only trauma hemorrhage, but also postpartum hemorrhage, and explains anemia management in resources when resources are limited. In upper, middle, and high income countries, you can find information on bleeding management also in the growing population of elderly patients undergoing elective cases. So this patient-centered approach has daily values to offer. PBM is indeed helpful. Why? Improved post-operative outcomes. So in fact, the patient is always in the focus. Reductions in morbidity in various organs, reductions in blood transfusions, shortening in length of stay, fatigue, delirium is less frequent, healthcare costs reduced. There's an increase in rehabilitation competencies, in possibilities, quality of life, and patient satisfaction. What else do you want? So the patient-centered approach is of value and of benefit. But how to deliver it? In 2013 and we published our first European ESAIC guidelines on the management of severe perioperative bleeding. In 2017, we published our first update, and in 2023, our second update. And I had the privilege, under my previous name, Sibylle Langenecker, to coordinate this European PBM guidance in elective surgery. We had relevant clinical questions up front. Which patients should be optimized and how before surgery? What about patients with preoperative anemia on anti-thrombotic drugs, with comorbidities involving the hemostatic competencies, chronic medications, inherited bleeding disorders? And how should intra and postoperative bleeding be stopped and anemia be managed? And you can find basically everything you ever wanted to know about bleeding management, from cardiovascular surgery over orthopedic surgery, visceral transplant surgery, etc. And how to handle post-operative anemia management. This was actually my chapter in these guidelines. So you can find a lot of information. It's free of charge to be downloaded from the European Society of Anesthesiology and Intensive Care, ESAIC, from the website. And why is it now an evidence-based guidelines? Because we did a systematic literature search in this last second update. We looked into the available body of evidence up to 21, and we retrieved, in fact, a huge, robust evidence of more than 85,000 publications. And the guidance is twofold. We reconfirmed guidelines and guidance from previous versions, and we enriched it by the actual search results. Here is a QR code for our condensed information in an application for smartphones. Our mindset in this individualized, patient-oriented European approach to perioperative medicine is avoid protocolized ratios of allergenic blood products, give only what is needed to the bleeding or anemic patient at the current stage, at this moment, and give it fast. We heard in the intro video, when seconds count. Bleeding emergencies are situations where seconds count. Our credo is stop bleeding before it gets massive, not to run behind, but stop it before it gets massive. This patient-based approach, as I would like to call it now, is what it really means in clinical practice is consider the patient and the surgery-specific risks. Check the clinical situation. Is there bleeding or not? Monitor appropriate lab data, and then correct coagulopathy and or anemia by calculating the doses of drugs you want to deliver according to an algorithm with predefined triggers and targets. And then recheck the clinical situation and eventually remonitor if you are already in your goal area. In the ESAIC guidelines, we have an exception for a ratio-based approach, which is only early in the treatment phase of uncontrolled bleeding in elective surgery. Just consider a case where the vena cava has a leak. And there, a ratio of greater than 1:1 plasma to RBC could be suggested with a low 2C grade recommendation or suggestion. How to guide management of coagulopathy? By measuring it. And predefined triggers and targets are recommended in viscoelastic hemostatic assays, if not available. And I think there are many participants coming from countries where these monitoring devices may not be available. Their conventional lab tests are proposed. So this is a screen from my hospital at home, so to say. We have this algorithm for a goal-directed correction of severe coagulopathic bleeding in elective surgery. And first, when using a viscoelastic hemostatic assay, we look whether or not there is a need for fibrinogen substitution, meaning we look for hypofibrinogenemia. We consider, of course, to correct any hypofibrinolysis before administering fibrinogen concentrate, which is our answer to hypofibrinogenemia. And we correct hypofibrinogenemia before we think to push thrombin generation by administering prothrombin complex concentrate. And for example, factor 13 deficiencies occur late in severe bleeding, massive bleeding, so this is not a first stage intervention. The ESAIC guidelines tells us when to give fibrinogen concentrate or cryoprecipitate, which is a alternative. This is in hypofibrinogenemia, documented, diagnosed, proven by viscoelastic hemostatic assays. When to use PCC, for example, again, when the deficiency in thrombin generation is proven either by viscoelastic hemostatic assays or by the INR. In bleeding patients on vitamin K antagonists and bleeding induced by these compounds, PCC is strongly recommended 1B, not plasma. Also in anti-10A agents such as rivaroxaban, a 2C suggestion is for the use of PCC. So this is how our summary of guidance derived from the systematic literature search looks like. And for example, a simple, trivial information is postpone any elective non-cancer surgery until preoperative anemia is corrected, 1A. So this is a strong evidence and strong guidance, but still so complicated to be followed and to be pushed through also in our OR management. So we put a lot of emphasis on monitoring throughout the critical phase in order to target our therapeutic and or logistic consequences. We start with preoperative blood counts and, if anemia is there, with further anemic assessments such as ferritin, transferrin saturation, monitoring. We do a lot of questionnaire in order to assess the risks of our patients, standardized bleeding and thrombosis questionnaires. Intraoperatively, body temperature is essential because coagulation is happy when there is normothermia. We check blood gases to correct eventually calcium deficits and acidosis. And of course, we measure blood loss in order to keep an eye on what is actually gone. And postoperatively, of course, we also check. And an algorithm for individualized RBC transfusion, not ratio-based, but again, individualized, considers not only the hemoglobin levels, but also the compensation for less oxygen transport and pre-existing diseases. And then single unit strategy is the answer, one RBC after the other and measuring in between. There's a lot of knowledge and skills that need to be there in the specialist. And so in the European Union, we have, of course, patient blood management inside of our ETRs, of our European training requirements. So each the anesthesiology specialty has PBM in the medical training included. The patient-based approach in bleeding emergency is based on the consideration that there is no specific phenotype of anemia and no specific phenotype of bleeding we can assess only by our eyes and by our inspection, for example. Yes, mucosal bleeding may be a hint for coagulopathy, but still you do not know, is it fibrinogen that is needed or thrombin generation that must be pushed? So our credo is, if you don't monitor it, you can hardly manage it. What could you do in countries where there are not resources available for monitoring and potent, specific, concentrate-based therapy? I think that a blind management is an answer, a potential answer, according to the most common or suspected pathomechanisms. For example, iron deficiency anemia is the most frequent cause rather than other causes of anemia, such as in renal insufficiency or chronic disease. Hypofibrinogenemia occurs first in severe or massive bleeding. Low thrombin generation is a later problem, and other factor deficits come even later. So one extrapolation or one word to trauma, which will be in the second lecture as well. A patient-based approach versus a ratio-based approach. Our, landmark study was published in 2010, and I'm very honored that I was part of it. But Herbert Schöchel is the initiator and the most important person in Austria, probably for supporting and preparing the evidence base for this patient-based approach. The goal-directed coagulation management has been proven to significantly reduce overall mortality, to significantly reduce mortality also in brain trauma, and to significantly reduce transfusions. All our goals we want to achieve. it took us, it takes only 60 minutes after emergency room admission to fix coagulopathy. Compared to the proper trial or the eitactic trial, this was almost half the time. It took more than 2 hours in the proper trial to get to this stage, when seconds count, when minutes count. So it is not surprising that this body of evidence entered the European Guidelines on the Management of Major Bleeding in Coagulopathy, 6th edition, published in 2023, where coagulation monitoring is advised to be based also on goal-directed coagulation management. If you ask patients, they want PBM. We prepared an information video for our patients, which is also available free of charge in English and German. With this, I would like to close. Thank you very much for your attention, and I'm very much looking forward to our discussion later on.
Thank you, Dr. Sibylle, for your great lecture. And we continue right now. Professor Jacques Duranteau. He is a professor of anesthesiology and intensive care at the University of Paris-Saclay. He is the head of the Department of Anesthesia and Intensive Care at Bicêtre Hospital and the president of the medical committee of the Paris-Saclay University Hospitals. He is the member of the National Committee of Universities of Anesthesiology and Intensive Care. Professor.
Thanks a lot. It's a pleasure to be with you. I just share my slides. Okay. Okay, so we know that the management of severe trauma is a challenge for healthcare system worldwide. It is the fourth leading cause of death in the world, and 30 to 50% of these deaths occurs within the first 24 hours due to the fact that we are not able to control hemorrhage. And this is the number, the percentage in a civil setting, but it's if we consider military situation, it could be largely higher. And so it's important also, I will talk only about civil situation, but it's important to keep in mind that we have to be smart in strategy to control coagulopathy during military situation. 1/3 of the bleeding trauma arrived in the hospital with a coagulopathic state. And we know that the management of trauma is really, it's a damage control strategy. And it's when we think about how to manage trauma, it's important to think how the trauma is organized in your country and what is the network of trauma hospital to be able to put the patient in the right place and in the faster we can. So it's this study from the trauma base, it's trauma base that we have in France, and you can see that the mortality increase with the pre-hospital time, and so it's very important to also be focused on the fact that we have to bring patient as soon as possible in a trauma center. And so what is our mission is first to stop the bleeding. And so the second point is to support tissue oxygenation by fluid, vasopressor, transfusion, and to support the coagulation. And so it's we are really in a damage control strategy resuscitation. And to try to prevent coagulation and to treat coagulation, we have to reduce dilution We have to prevent hypothermia, reduce acidosis, and an early restoration of effective coagulation with a goal-directed algorithm for hemostatic resuscitation. So the first thing is to apply the concept of low volume fluid resuscitation and permissive hypotension. We have not to try to improve arterial pressure at a too high level because it will increase the bleeding. And this is the recommendation of the European guidelines on management of major bleeding and coagulopathy following trauma. And you can see that what is great is that even if we can discuss this, there is a target of systolic arterial pressure. It's that we have to try to respect until major bleeding has been stopped, and it's important if there is brain injury with trauma, we have to increase the level of mean arterial pressure even if we increase the bleeding. But if there is not, we have to stay with target of systolic arterial pressure within 80 to 90 millimeters of mercury. So low volume resuscitation, it's not no volume resuscitation because we have when we have to deal with an hemorrhagic shock, we have to give fluid and we induce dilution. But we have to be concerned by this and try to, when we give fluid, we try to give successive bolus, for example, of 250 milliliters, and see the response in terms of arterial pressure to try to not to give too much fluid. And another thing is that we can add vasopressor to help us to maintain arterial pressure and without giving too much fluid until we are able to control the bleeding. So just this slide to show you that it's a review on US Trauma Center, and just to show you that how we decrease drastically the quantity of the crystalloids that we give to our patient, and we decrease this quantity of fluid, so it's good because we have less dilution. And in parallel, we increase the transfusion. And I think it's a big change if we consider the 10 years after. And so you can see that if we look at the guidelines of the European guidelines, you can see that it is recommended to early and to repeat monitoring of coagulation and to have a goal-directed strategy guided by standard laboratory coagulation value and by viscoelastic monitoring. What is the ratio of FFP and red blood cells? It's a ratio of at least 1:2, and it's the recommendation is also on fibrinogen and cryoprecipitate, and it's there is really in Europe two way to do. The German country are more for fibrinogen, early fibrinogen, than the France or Spain, which where we really are in FFP red blood cell ratio of at least 1:2. But really in Europe, the two strategies now are mixed. And there is a target of hemoglobin of 70 to 90 gram per liter. And I think we have in the future to reconsider this maybe in a trauma brain injury. and a suggestion for a high platelet red blood cell ratio. Tranexamic acid has to be given as early as possible, and fibrinogen concentrate has to be given if there is a significant bleeding with functional fibrinogen deficit or a plasma fibrinogen lower or equal to 1.5. So I want to highlight the fact that it's very important to anticipate things and to anticipate the treatment of coagulopathy. So we apply in France this score during the pre-hospital phase. It's based on 5 criteria. Shock index greater than 1, capillary hemoglobin on the field lower or equal to 13, miniatal pressure lower or equal to 70, pre-hospital intubation, pelvic trauma. If we have 2 criteria, we start to be prepared to give massive blood transfusion in the hospital. So it's a simple score, and so it's important to have in each country here's a proper score during the pre-hospital phase. It's for an hospital guy as me, it's important because we can prepare the team to receive a patient who will have an hemorrhagic shock. So if we have 2 criteria, we start thinking as we have to face to an hemorrhagic shock. And so immediately before the patient arrived, we order 4 red blood cells O plus 2 FFP, and this is in thermostatic container, so we can use it, or if the patient is stable, not use it. And so it's very comfortable because immediately when the patient arrived, and if we have an instability, we start to give red blood cells. So really, red blood cells is the fluid of resuscitation, and it's why we give less and less crystalloid. And after, we order PAC, and we monitor coagulation. We can discuss of this after, but it's so we have a strategy of PAC, and in parallel, we monitor our coagulation at the bedside. And I just put this, what is your protocol, and we give platelet, fibrinogen, and tranexamic acid with a monitorage of coagulation. So platelet, what the European guidelines recommend is to administer platelet to maintain a platelet count above 50, and the maintenance of platelet count above 100 if the patient we have an ongoing bleeding, or if we have a trauma brain injury. And if administered, we suggest an initial dose of 4 to 8 single platelet unit or 1 apheres pack. So if we think about how I can control the coagulation as soon as possible, it's also important to think about do we have to perform transfusion before the arrival of the patient at the hospital? And it's a very important point, and even more if we consider military setting. And so there is an ongoing discussion on this. I just want to show you this study performed in UK, where they give during the pre-hospital phase, they give 2 units of red blood cells and 2 units of lyophilized plasma, and they observe no change in mortality. So it's a negative study, but I just want to highlight the fact that there is a lot of bias in this study, and I think that we have to reconsider this and just to still working on the fact that maybe we have to give to start transfusion during the pre-hospital phase. So it's when you look at this study, it's the trial treatment was initiated more than 56 minutes after the call of the emergency service. And so before randomization, the patient received 430 milliliters of crystalloid, and blood pressure was 73. And so what was important is the low prevalence of coagulopathy with a high mortality in this study. And really, there was question about the fact that there is a so high mortality in this population, and there is a large proportion of patients with an head injury, which have an impact on mortality. And there is a lot of patients who had a cardiac arrest, and many patients in both groups were excluded from the analysis. So during about pre-hospital blood product use, the European guidelines highlight the fact that there is conflicting data, and so there is no, we don't do clear recommendation and in favor or against. And I think that it's important to have a good study on this topic. Just this study that we perform in France, so about the early administration of 4-factor prothrombin complex concentrate. And what we observe when we give this PCC in the early phase of hemorrhagic shock, we observe no change in mortality and no change in the transfusion. In the two groups, the transfusion was the same, and but there is more thromboembolic events. So it's a negative study for the use of this PCC in the early phase of trauma hemorrhagic shock. And we saw with the previous speaker, when the patient had anticoagulant, what are the recommendations, and just to keep in time, I conclude with the fact that it's very important to support the coagulation, to first to have an efficient network of trauma, and it's so I think it's very important to push everybody to build this trauma network, because it's at a huge impact on the mortality. And so it's not the fact that it's important to be very aggressive in transfusion, but also it's important to stay in a damage control resuscitation, and to reduce dilution, to keep a target of arterial pressure, prevent hypothermia, and reduce acidosis. Thanks a lot.
Thank you, Professor Duranteau. And we will move on to our third speaker. But before that, I would like to encourage those of you submitting questions. We've been looking at those questions. Many of the questions are relevant to lower resource settings, which are so these are excellent questions that we are happy to deal with in our upcoming Q&A session. So hang on, stay with us. We will get to the responses to all of those, and but we will first continue with our third speaker. So our third and last speaker is Professor Chiara Robba, who will be talking about minimizing cerebral hypoxia and severe traumatic brain injury. She will join us for the Q&A. She's currently very much taken up in the ICU because of a tragedy that's going on now. Professor Chiara Robba is a professor and head of neuro-ICU in the University of Genova, Policlinico San Martino. She has a PhD in neurosciences and is past chair of the neurointensive care section of the ESICM. She's also associate editor for neurocritical care and the deputy editor of intensive care medicine, no less. She has published more than 500 peer-reviewed papers, mainly on neurointensive care and extracranial complications after brain injury. On a personal note, I've known Chiara since she was a young resident, and it's a great honor to be able to present her in such a manner. She's very deserving of this session.
Thank you very much, Sharon. And on a personal note, it's an honor for me to be introduced by you. You have always been one of my role models. I'm going to discuss about how to minimize the cerebral hypoxia, but I have slightly added an additional point, which is that we also have to avoid hyperoxia in severe traumatic brain injured patients. So this is a sort of a agenda of what we are going to discuss. And I think that what we need to understand when we talk about cerebral oxygenation is that the cascade of events which lead to the number that we see, which is the systemic, or if you're available, the cerebral oxygenation, is the result of a huge number of cascade of events, which of course start from the amount of oxygen in the blood, but takes in consideration a huge number of pathophysiological issues, which are related to cerebral blood flow, oxygen content, oxygen delivery, oxygen metabolism, how the brain uses the oxygen that we deliver to it. And there is a very dangerous crosstalk between the brain and the lung. And we shouldn't trust each other, because sometimes when we give a therapy to manage a traumatic brain injured patients, at the same time we are affecting the lung. Think about when we give barbiturates or hypothermia for brain injury, when we tend to have hypertension. These are all factors which can create a sort of a cascade of events. And in fact, if we look at the number, the incidence of pulmonary complications after brain injury is very, very high. It's much higher than in the general ICU population. It's around 20%. It's a very huge number. Which are the problems with hypoxemia? So actually, we all know that since many, many years that we should avoid hypoxemia in brain injured patients. This is a sub-analysis of a center TBI study, which is one of the largest observational studies on traumatic brain injured patients. And we focused here on secondary early systemic insults. And the major ones are basically hypoxemia and hypotension. And of course, a combination of the two makes things really worse. And the presence of early, so early means in the pre-hospital, but even in the emergency department phase, influence then everything that happens afterwards, from the ICU management, ICU admission. Patients who have early hypoxemia, for instance, develop higher cerebral edema. They need more often neurosurgical surgery. And as you can see from this picture, create a huge release in what are the novel cerebral biomarkers. So it's an important cause of secondary brain damage. And this is why I don't think it's surprising that when we use the scores that we apply to our patients when the patients arrive, we do prognostic scores, and one of these is the impact score. Hypoxia together with hypotension are in this score, and they are in this score together with intracranial factors like the GCS, the presence of intracranial hemorrhage, etc. So this means that their impact on the brain is huge. And the impact on the brain is huge because, of course, the brain is importantly dependent by oxygen. So when there is a depletion of oxygen, after already a few minutes, what starts is an anaerobic metabolism with energetic failure. But I also would like to highlight the fact that if we are too generous with FiO2 and with the oxygenation, we go on the other side of the coin. So an increase in hyperoxemia can cause itself a damage to the brain because it causes an increase in the oxygen radical-free release. So which are the evidence? Let's start from the guidelines. These are the guidelines that we did some years ago with Sharon, with Jacques. And the problem was that all these guidelines are based on a very, very low level of evidence. So this is the first point. We obtain a strong recommendation regarding the targets of oxygen, regarding the fact that we need to avoid hypoxemia, but this is again based on low level of evidence and mainly on the Delphi approach, which means more an expert evaluation, an expert discussion. The targets that were set in this consensus were from 80 to 120, but again, no strong evidence are related and not specifically in traumatic brain injured patients regarding whether these targets are correct. The good news is that probably over the years, the clinicians put more attention in avoiding hypoxemia. If you look data from 20 years ago, the incidence of hypoxemia in TBI in the emergency department was around 25%. These are some new data, and the incidence of hypoxemia as defined by the guidelines was around 13%. What is more common is definitely the mild hyperoxemia. This is, in fact, a cohort of the ENIO study, which is a large database of 1,200 patients. And as you can see on the left side of these slides, the incidence of hypoxemia is much lower than the incidence of hyperoxemia. Probably because over the years in the neurointensive care community, it's been pushed a lot against the presence and the occurrence of hypoxemia. And when is it more common? Well, from these 13% in gray here, where we start, which is the incidence of hypoxemia at admission, hypoxemia tends to increase over the days. At the same time, hyperoxemia is more common on day one. The interpretation of this data, in my opinion, is that in the very early phases of trauma, what we tend to do is to increase the FiO2, to be very generous with FiO2, trying to avoid the secondary brain damage. And then over the ICU stay, there are the development of pulmonary complications, which can importantly affect gas exchanges. And when we built with this database, the U-shaped curve, trying to find the best threshold for mortality, we found a lower threshold, which is comparable to those that we suggested in the guidelines, around 84 millimeters of mercury, and a slightly higher values of increased mortality for hyperoxemia, 195. But again, this is an observational study, and we don't have a randomized control trial which can demonstrate this. Even more recent data are those from the Venti Brain Study, which is a large observational study, 2,000 patients included in this study. And these are the results in terms of oxygenation in brain-injured patients. And as you can see at admission, the median PaO2 is around 113. So it's not a bad number. It's a good number, actually. And as you can see, even if not statistically significant, there is a tend to be reduced over the days. These are the days of admission with daily mean value of oxygenation, with at the same time a tendency to increase the CO2. What we also noticed was a huge variability across different countries, and this is a caterpillar plot which represents the countries that were in this database. As you can see, there are huge differences according to local policies, and I believe this is related to the fact that the guidelines are based on a low level of evidence. And when looking at the association with mortality, this is what we obtain. So again, a U-shaped curve with a steeper curve, of course, in the area of hypoxemia, but there is still a tendency to increase mortality when we are too generous in terms of hyperoxemia. We are working on a specific sub-analysis on oxygen to go deeper in this. And we did not find any effect on 6 months neurological outcome. But in my opinion, this is also related to the fact that we use the GOSE score that doesn't really detect, in my view, in a specific way, the quality of life of the patients. So now we discussed about physiology and evidence. Now it's time to treat our patients. We have a patient which arrives and we have a systemic or a cerebral desaturation. We will discuss how to monitor it. My point here is that what we see is a number of PbTO2 or SpO2 or PaO2, but this number is the result of a number of factors. In fact, to treat cerebral oxygenation, we need to keep in consideration a huge number of factors, which can go from, of course, the systemic oxygenation, but also the cerebral blood flow. So the blood pressure, for instance, the target of oxygen, the target of CO2, the control of ICP, the hemoglobin, the temperature. This is an example. It's a very simple algorithm which highlights exactly this. So when you have a number of cerebral hypoxemia, what you need to do is to think, so check the map, check the arterial blood gas, check the oxygen transport, check the oxygen optimization, check whether the brain needs more or less oxygen in that moment. And this depends on brain activity, so on sedation, on the depth of anesthesia, temperature, seizures, and on cerebral stimulation. So cerebral oxygenation is the result of the flow and the difference of the content of oxygen. And all these factors included the oxygen diffusion, which is quite difficult to be detected clinically, but is also an important factor, so especially when we have a cardiac arrest together with a trauma. All these factors needs to be taken in consideration. It's not surprising that a lung injury, let's imagine a thoracic trauma with a low PF, is associated with low values of cerebral oxygenation. Regarding the values of hemoglobin, well, there is a lot of ongoing discussion because we have a very recent randomized control trial. This is a physiological study which demonstrated higher episodes of cerebral desaturation when the values of hemoglobin are below 9. And the TRAIN study, which is one of the 3 randomized control trials recently published on hemoglobin threshold, demonstrated a benefit in terms of neurological outcome when the patients have a liberal transfusion target, which is 9 versus 7. And I believe, I mean, we can discuss this later on. This is going to change the new guidelines. But sometimes to treat cerebral oxygenation, we need to treat the cerebral edema. This is an example of a patient you see here is monitored continuously. At some point, there is an increase of intracranial pressure. You see this peak here, and this is how cerebral oxygenation behaves. So it is, of course, dependent on the cerebral edema because this causes alteration in the flow at the level of the brain. So sometimes what we have to do to improve cerebral oxygenation is simply to treat the cerebral edema. And very often, as it is importantly related to the cerebral blood flow, the association with improved cerebral oxygenation is related to the values of blood pressure. But again, we will discuss later on, and I think Jacques has mentioned the fact that sometimes it is allowed a sort of protective hypotension, but when you have a brain injured patient, things and the targets of arterial blood pressure, of course, importantly change. And finally, how can we monitor the cerebral oxygenation? Well, we have a number of toys, which are the multimodal neuromonitoring tools. And among these, we have 3 main methods to assess the cerebral oxygenation. The first one is the jugular bulb oximetry because it's one of the oldest methods. It consists in sampling the jugular bulb. So it is quite invasive, despite it's not that difficult to use it. And then sampling this, you obtain a value of cerebral oxygenation, which is a global value because it takes in consideration all the hemisphere. Normal values are considered around 65%, and episodes of desaturation associated with worse outcome are considered below 55%. There is a lot of debate regarding this type of monitoring tools because it's global, because can be contaminated by extracranial venous blood, like the facial vein. Personally, I still use it and I like it a lot. NIRS has the advantage of being non-invasive. Of course, it consists in the use of a light source with a detector. And as a result of this, you obtain something like this screen. So you have the global cerebral oxygenation, and you have also the different components of venous and arterial content of oxygen. Be careful because NIRS has, in my opinion, many limitations, especially in trauma, where you might have blood, hygroma, or other factors which can alter the signal of the NIRS. And this is a very funny study from Nino Stocchetti in Milan, which compared the values of NIRS in patients in brain dead and medical students, and he found no significant, only a slight significant difference among them. And but this is related to the contamination of the extracranial component, of course, and not to the Italian medical students. Finally, brain tissue probe. This is probably the most used tool to assess and measure the cerebral oxygenation. It is based on, it is invasive. It provides a local assessment of cerebral oxygenation. It is a Clark electrode, which is able to assess the PbTO2. And according to the literature, the values, the threshold, which are associated with a bad outcome are below 20 millimeters of mercury. This is one of the observational studies that demonstrated the association with the outcome with lower values of cerebral oxygenation. And there are some consensus guidelines and international algorithm which recommend to insert PbTO2 and which recommend to take in consideration the interplay between ICP and PbTO2 with different algorithm of treatment, of course, because it really depends on whether the patient has or not cerebral edema or whether the patient has or not cerebral hypoxemia or both. And the pathophysiology is completely different. We have one randomized control trial. We are waiting for other 2 trials regarding the effect on the outcome. This was a negative trial in the whole population, but there is a signal in the benefit of PbTO2 in the subgroup of patients who have intracranial hypertension. So I'm not surprised. So in conclusion, the pathophysiology of oxygen and brain is very complex. And of course, we need to minimize the cerebral hypoxemia because it's a way through which we protect the brain. Don't forget that even hyperoxemia can be detrimental. So don't be too generous with FiO2 and check continuously the values of oxygen. The target is the brain. So if you have a possibility, you should use monitoring, brain monitoring, which allows to assess cerebral oxygenation. And remember that the number that you see using this monitoring is just a number, but is the result of a huge number of pathophysiological factors. So when you see this number, think about the pathophysiology. Thank you very much for your attention.
Thank you. You have finished perfectly on time as usual, and all of the speakers have, in fact. And I think that I'd like now to introduce our panelists. We have Dr. Balavenkatasubramanian from India. I hope I got that right. And and he is a senior consultant and academic director at the Ganga Medical Center, Coimbatore, and the president of the Indian Society of Anesthesiologists. He heads the WFSA Ganga Hospital Regional Anesthesia Fellowship and specializes in regional and orthopedic anesthesia, perioperative medicine, and education. Unfortunately, our additional panelists will not be attending today, but I think we have a fantastic group of people to respond to the Q&A. So I'm going to start actually with the questions that the audience has proposed, although we have prepared a series of questions, because I think if the audience is asking some of these things, it must be boiling their blood to get in there. So first of all, regarding the PowerPoint and the presentations will be online. You will have access to all of that, and you'll get the details later on. And you have, if you look at the chat, you will see the materials are at comms.wfsahq.org. I would like to talk about target MAP. This is a question that was raised in the discussion. Dr. Bala, would you like to start? And Dr. Langenecker, would you like to start about target mean arterial pressure?
Thank you, Sharon. And as a secretary of the World Federation of Society of Anesthesiologists, to begin with, I wanted to thank the 3 brilliant talks and the excellent moderators who have given their time for this. And on behalf of the board, I thank our Intensive and Critical Care Committee, headed by the committee chair, Sheila Maitra, for organizing this marathon meeting. I also work in a trauma unit, so I wanted to make a couple of observations before I go on to the question. Number one is this World Anesthesia Day has been said anesthesiologist in managing emergencies. And I personally feel one of the most important things that every anesthesiologist who is attending this session should master is point of care ultrasound. And every second that is lost in a bleeding trauma patient, when it is internal, it's because of the inability of the attending healthcare worker to detect an intra-abdominal bleeding. So in our institution, we made the capacity building of every anesthesiologist to do it. So you don't wait for a radiologist. The minute a trauma victim arrives, I think immediately to get on there, and if it's bleeding inside, to take them for a resuscitative laparotomy immediately and source control. And in pelvic injuries, if you put an axial fixator and you see that he's not stabilizing, to think of therapeutic embolization and involving an interventional radiologist. I think I just wanted to start with these 2 observations. And it's an excellent question on the mean arterial pressure. And I think all of us know that the mean arterial pressure that needs to be maintained and very nicely enumerated in a patient in polytrauma with head injury and without head injury. With head injury, you need to keep the mean arterial pressure higher and a systolic of around 100, and it could be 80 if it's without a head trauma. Most important point to remember is the mean arterial pressure to be maintained before source control and after source control. And many centers, which I visualize, is overzealous infusion of crystalloids on arrival and taking the pressures very high. And the point is pop the clot, and there is a massive bleeding happening again internally. So probably we need to decide before controlling the hemorrhage and after controlling the hemorrhage, what would be the mean arterial pressure. So these are my points, and I want to give it back to Sharon.
Dr. Langenecker, would you like to provide input on that? I mean, with the guidelines, do you think you can separate anemia from blood pressure?
I mean, I could not agree more. We need a fast ultrasound workup of the patient to identify bleeding sources. We need POCUS, and we need the experience and skills in doing this and interpreting the results and taking consequences out of the results in the diagnostics. Still, I'm with norm retention, going for well perfused kidneys and brains, and in the guidelines on elective surgery, of course, we again look at the patient's characteristics. So looking at pre-existing diseases, the normal blood pressure, mean arterial pressure for this specific patient, looking at the compensatory mechanisms may be recommended. Anemia and blood pressure, I mean, if you have less oxygen transport capacity, you need flow. this is not the same as mean arterial blood pressure, but you need flow in order to deliver it to the vital organs, and you need a good volume management. Jacques has talked about that. So a good volume measurement, volume monitoring, volume treatment to compensate for any intravasal deficiency is important.
Thank you. I would like to.
Sharon,
Can I add just one point?
Yes, sure.
Thank you. I totally agree with my colleagues. I would like to really highlight the role of POCUS in this setting, because POCUS allows us not just to assess the volume, which is fundamental, to target, to drive administration of fluids, but can also give us an idea of the cerebral blood flow. So if we add to the common FAST, even a quick transcranial Doppler, and it's a technique that doesn't really require a huge training, we can already have an idea of the cerebral blood flow and of the intracranial pressure. So in my opinion, guidelines are those that have been mentioned by my colleagues, but we are, I think, moving towards an individualization of the targets, of the values, which are based on physiological parameters. And this is a physiological parameter. So my recommendation is, of course, guidelines, but stick to physiology, use physiology. In this case, we have POCUS, which is quick, of course, needs training, but it's feasible. So you can discriminate like a patient with previous hypertension, whether the flow is enough or not, and target it according to systemic pathologies.
Right. I just would like to point out that this week, Dr. Bernd Saugel published a paper on individualized blood pressure with matching to the previous blood pressure, showing actually no difference with individualization. I would like to propose that one of the problems is the fact that we're looking at every variable separately and perhaps not adjusting enough. Our ICU and trauma environment is very, very complex. Professor Duranteau, you have your hand up, and then I want to ask a question about the WHO PBM.
Just if I can make comments on the fact that I'm completely agree that to correctly manage trauma, it's very important not to lose time, and very important to have a dedicated team. So it's an organized and trained team. So simulation is very important to train your team. The second point is completely agree with Chiara when she highlights the fact that it's important to individualize the strategy, and when we have to take in charge of patient initially with bleeding problem, the transcranial Doppler, when there is a trauma brain injury, could be a good way to set up the target of arterial pressure. Because if you have a good Doppler, transcranial Doppler, at a certain level of arterial pressure, you can stay at this level of arterial pressure. So I think it's a good way to target the arterial pressure. And I want to do the same comments that you do, Sharon, that after stopping the bleeding, what is the right level of arterial pressure? We don't know. But I personally, I very prone to increase the arterial pressure when we have to deal with an hypertensive patient. But the work of Bern is not in favor of this. So I think the story is not over. And we are starting a study in high-risk surgical patient, looking at hypertensive patient to see if a different level could be what is the good level of mean arterial pressure.
Thank you. So I would like to bringing up to the next question, and then I'll leave time for Hans and Kajal to ask questions as well. So bringing up to the next question, if each one of you had to choose, I mean, a lot of our listeners today are people that don't work in environments that have high-level monitoring and expensive. I don't know if you know, but a unit of blood can cost something like almost $500. Platelets can cost almost the same price. Very, very costly. What monitoring tool would you choose best if you had the funding to buy one? What do you think you would recommend that people ask their hospital directors or their EMS directors to get?
So, Sharon, can I go?
Yes, please.
So one of the things which we see is in relation to the blood pressure and the existing hemoglobin level, I feel one of the simplest of the investigations that would need to show us the adequacy of resuscitation, which is not expensive, is the serial lactate levels. And in spite of having a normal blood pressure, if there is a microcirculatory distress that we know that happens, which produces increased in lactate levels. So I think in centers which do not have the very expensive equipments, I would consider serial lactate estimations to be a guiding force on resuscitating a trauma patient. So that would be my take.
I would jump in and say, again, I agree with you. Serial lactate monitoring is helpful. But if you ask me what I would like to have, I would like to have an idea what is going on at the mitochondrial level. What is the stress there? What is the status there? Or what is the microcirculation really look like? How is the not only the output parameter of lactate, but what is really going on at various organs, various sites of the body in terms of microcirculation, because blood pressure is only a macrocirculatory any parameter, just a parameter we can measure easily. But the true story is going on somewhere else. But still, I agree, what we have at hand now is blood gas analysis worldwide. But in bleeding patients, to have a point of care monitoring allowing us to assess viscoelastic changes would of course be helpful in order to target coagulation management. And if I could ask for by one monitoring, because I think that blood gas analysis will be available in many centers globally. At least this is my impression. Correct me if I'm wrong. But if it is a question going beyond that, I would ask for a viscoelastic hemostatic assay, or at least a fast fibrinogen monitoring, because this is a pathomechanism of bleeding number one.
I think the main issue is the cost of the consumables with the viscoelastic monitor. That's still an issue, and hopefully will be overcome in the next few years. Dr. Hans, would you like to continue?
I just want to complete the answer. And I think that, of course, we have changing about viscoelastic tests, but the problem for most of our hospitals with not enough resources is that we don't have that kind of tools. So we need to monitor just usually with the vital signs. That's all we have. And with the military experience in countries like mine, like Colombia, that we have had some military hospitals on the field, we don't have all the resources for monitoring, for transfusion, and maybe is the majority of the conditions for many of our colleagues. So we need to change to improve these coagulation monitoring tools or hemodynamic monitoring tools that we have, or for traumatic brain injuries. But if we don't have that, I agree. I don't know whether you think that the ATLS continue to offer for these scenarios where the resources are not enough, and we can use these recommendations based on the clinic evaluation, based on the basic monitoring, using the shock index as a predictor, even for massive transfusion protocols. So we need to adapt these kind of recommendations for hospitals with not enough resources as the trauma centers. That's it.
Sharon, may I?
Yes,
I
please.
comment?
Please.
So it's a very good question. So my choice will be good surgeon. No, it's a joke, but it's so important. It's so important. The second point is lactate. It's great. The third point is if I consider coagulation, I think the first thing is to establish a clear strategy with your blood bank. And so it's to make choice depending on what you have. And for example, the ratio, it could be 1:1, but we have to remember that 1:2, it was no change in mortality in the proper study. So it could be one choice. And there is other. And about viscoelastic test, it's very helpful to decrease the number of red blood cells that we have to use, in my point of view. But it's important also to anticipate and to start with PAC. So I think that if I have a problem of cost, I will start with a standard coagulation laboratory test.
So basically, I will just, because I would like also to hear Kajal about this, and maybe she also has additional questions. I just want to summarize. So you're saying that for patient blood management implementation, the use of viscoelastic test, and the way we could sell it to the hospitals basically is say it will save them money. I think that's a good point to bring across to settings that have lower resources, and get your team well trained and use what you have to the best that you can, including lactate. This is what the summary. So Dr. Kajal, could you please pick up from here?
So just wanted to ask, like we are talking about viscoelastic testing and we're talking about the clinical markers. So I just wanted to ask Dr. Bala, like we are going as, low as monitoring urine output also in certain situations where there is nothing available at all in very primitive centers. It's used as a surrogate marker of perfusion in certain centers. Do you want to make a comment on that, Dr. Bala?
So I think, of course, yes, but the point is lactate is something which can be had in every institution because it's not expensive. Because urine output, again, it's not a clear marker of microcirculatory perfusion. And we know that when there is more of microcirculatory hypoperfusion, the pro-inflammatory substance released are much more. And though the patient may survive, then might develop systemic inflammatory response syndrome later. So it's very crucial and important that, though I agree that urine output is an indicator, but I think all of us have to graduate at least one level above to do the serial lactate estimations to really look what's happening to the tissues. That would be my take.
And Dr. Chiara, if I may ask you, what would be the transfusion triggers in severe to moderate TBI? Although you had shown in your pictures the TRAIN trial and the Emotion trial. So what would be your take for liberal or restrictive in these settings?
So I have to be honest that in TBI, I have always been a bit more liberal than in the guidelines. So this is just to be fair. However, I think that over the last year, we have published 3 randomized controlled trials, which at the first look might be in contrast, but at the end they are not. Because the Emotion trial, which specifically focused on traumatic brain injured patients. These are all phase 3 trials, so well powered with a very good methodology. So the motion compared 10 versus 7 of values of hemoglobin and found no difference in mortality. But looking at the patients who survived, those who received the liberal treatment in terms of hemoglobin had a better neurological outcome at 6 months. So primary outcome on mortality was negative, but looking at this data, there is already a signal. The TRAIN study, which was the randomized control trial that I showed, 7 versus 9, so slightly less liberal, showed a clear effect on neurological outcome with beneficial effect in the liberal group. And this is consistent even in the sub-analysis, which take in consideration TBI, subarak, and other types of brain injury. And finally, there is the Sahara study, which compared 8 versus 10. The unfavorable outcome between the two groups was not different in terms of the primary outcome, but no difference in functional outcome. But there is a signal that in the liberal group, there is a reduction in the vasospasm occurrence. Putting together all these trials, there is a very recent meta-analysis which has been published. The signal is clearly in favor of a more liberal target. The guidelines so far say above 7. I believe that when the new guidelines will be revised for TBI, the target will be more liberal, and this is actually also my practice.
So would this also take into account the severity of TBI? Like the more severe, the more brain hypoxia, the more useful it would be to have, higher targets?
Absolutely. And as I was mentioning in the presentation, a huge factor which can affect cerebral oxygenation and therefore outcome is the pressure, the intracranial pressure. So the more severe is the brain edema and the worse is the ability of oxygen to be delivered.
I think we are running short of time. If Dr. Sharon can tell us if we can take further questions or we need to wind it up.
I would like to conclude with the last question, maybe. We have the time.
5 minutes.
We have a video coming on in 1 minute. I apologize, but so just to wrap this up, I'd like to thank our speakers. I think these were great talks, of great clinical importance. The panel was very helpful. Dr. Bala, Dr. Garcia, great contribution. Dr. Jain, thank you very much for your contributions. I think both of you brought very important input from countries that are a little bit different than Europe. I think that we can put on the video now for the end of the session.
Thanks a lot.
Thank you.
Thanks a lot.
Thank you so much. Thank you.